I'm Keith Fox, and here we are at the end of day 2 of the American College of Cardiology in New Orleans. And I'm delighted to be joined by 2 key experts, because today has been a really exciting day. We've seen studies that are going to be changing practice, and I want to get your insights into just how this might happen. Firstly, well known to everybody, Dr. Catherine Otto, who's a professor of medicine and I think head of the valve service in Seattle, and also editor-in-chief of Heart. Freek Verheugt from the Netherlands, who is a real expert in coagulation and thrombosis. So welcome both of you.
Thank you, Keith.
Thank you. Catherine, first of all, let's talk about 2 independent trials using different valves for TAVR in patients with severe aortic stenosis but low surgical risk. So this has been quite a revolution.
Yeah, I think this is really going to change how we think about these patients. I think that the equivalence and even superiority of transcatheter valve replacement over surgical valve replacement in the 1-year outcome is a very impressive data. It's really going to change how we think about these procedures.
So we're talking about PARTNER 3 and Evolut low risk, 2 independent studies presented together here.
Yes, and they both show equivalence or better outcomes with transcatheter valve. And I think it's very exciting. So, as I think about my patients over the lifetime of the patient with aortic valve disease, because it really is a lifetime disease, and when we replace their valve, we replace the diseased native valve with a prosthetic valve which has its own risks and problems with deterioration over time. So I think though it's going to change how I think about those patients. Instead of first considering what is the patient's surgical risk, are they high, low, or intermediate risk, I'm going to instead be thinking about my patient in terms of what is this patient's expected longevity and what is the expected longevity of the valve prosthesis in this patient.
So critically important point. We know something about valve longevity, but not much beyond 5 years in big numbs.
With the transcatheter valve.
With the transcatheter valve.
Some of the surgical bioprosthetic valves have had very excellent outcomes out to 15 to 20 years. We all have patients with those valves, and we also know that the durability of a bioprosthetic valve is inversely related to age. So if I put a bioprosthetic valve in a younger patient, it lasts fewer years than if I put it in an older patient.
And there is accelerated calcification even in some young people, isn't there?
Yes, exactly. So as I think about my patients, if I have a patient whose expected longevity is less than the expected durability of the valve, I'm very confident that this is a person who should go for transcatheter valve replacement. If the patient is, has a longer life expectancy, which often means a younger patient, and there's concerns about the durability of the valve, which again is often a younger patient, I think I would be hesitant in making that my first choice. And in either case, I think really the critical thing here is going to be how do we inform physicians and importantly patients about the risk benefits. We would all choose to have a non-surgical procedure if outcomes were equivalent, not just over the short term, but over the long term. But patients are going to be willing to take higher risks or discomfort and pain up front if it results in a better long-term outcome. So we need to figure out how to really communicate with our patients.
So, one of the impressive things was the really excellent surgical results in the surgical arm. So it wasn't as though these trials were comparing against substandard surgery. They weren't. They were really superb. But my understanding is some of the surgical valves that were implanted were self-expanding valves that are very like the TAVR valves.
Yeah, and that surprised me a little bit. I think if a patient is having surgery, I most often would want them to have a more well-known durable valve that's been out for many years, and I think that the self-expanding valves are more for situations where that's surgically a better approach. So I think that'll have to be taken into account, is which is the best valve, which has the best durability, and only time will tell. And in the meanwhile, I think we have some challenging times ahead in deciding in each patient what's the best valve for this patient.
So in a true sense, these 2 are landmarks in changing our thinking, but there's still a place for some of the surgical replacement of valves. Are we going to have the surgeons maintaining enough competency, doing enough valves?
Yeah, I think we are, because I think that there's, the patients in this study were very carefully selected. You have to have a valve anatomy suitable for transcatheter valve, a valve size that's going to fit the transcatheter valve, the coronary height, and then the vascular access. And it was really remarkable to me how few women were in these studies. It was only 20 to 30% women. I would have expected 50% or higher. Bicuspid valves are more common in men, but those are younger. And so this was a mean age of 75 years. So,
and bicuspid valves were excluded.
They were excluded, and so why were the women not in there? So is it that there's some bias in referring physicians that they weren't even considered for the study?
It's possible.
Or is it that, and that could be because we're defining severe AS incorrectly. Maybe women more often have low flow, low gradient severe AS.
One other point I want to bring out is that in the early days of TAVR, there was concern that there was more stroke in the TAVR side than in the surgical side. Actually, it's the reverse now.
And that's now reversed. So I think that's, again, there's no question these are landmark studies that are going to change our practice, and surgical risk is no longer the determining factor in which valve we choose.
So for many of our patients, even those that are low surgical risk, TAVR is now a very good option.
Exactly.
Okay, so let's move to another landmark, the AUGUSTUS trial. The AUGUSTUS trial, which was a very elegant design, factorial design. Freek, tell us more about that.
Yeah, we have seen 3 earlier trials of patients with atrial fibrillation undergoing PCI, and they were randomized to VKA or NOAC. And many interventionalists were a little bit afraid of NOAC because you don't have an antidote. What is the optimal dosing when you go to the cath lab? But I think 2 earlier trials show that it has good results to use a NOAC rather than VKA. Another issue was, of course, the use of aspirin. Aspirin dramatically increases the bleedings in patients who undergo an intervention while on an anticoagulant. And 3 earlier trials have shown that if you leave out aspirin, the bleeding is dramatically reduced. And therefore, aspirin is a major contributor to bleeding in these, of course, elderly population with AFib undergoing PCI. But the 3 previous trials were all a little bit too small to be conclusive. And now we have...
But Freek, even if we go back to the original AUGUSTUS trial, it said triple therapy produces more bleeding.
Yeah, of course.
So this has told us triple therapy produces more bleeding.
Yeah, of course. If you give 3 drugs together, that all increase bleeding by themselves.
But very elegantly, there was a factorial design here of aspirin or no aspirin.
Yeah, exactly. And that was what we missed in the previous studies. It was open label aspirin. And here it was double blind analyzed after the randomization of VKA versus apixaban. And I think that made the trial not only by size very interesting, but also by its better design. And the results were very clear. As expected, apixaban was safer than VKA, as shown in the earlier
Safer
trial.
In terms of less bleeding?
Yeah, because bleeding was the primary endpoint, as it was in the earlier trials.
Yes.
So that was not unexpected. Ischemic outcomes were very similar between VKA and
we must be clear that none of the studies, even this study that is much bigger than the others, is sufficiently powered for ischemic endpoints.
Exactly, we should realize that. And I think you need at least 15,000 patients to show that, at least for the aspirin side, that it is non-inferior to continuing aspirin rather than dropping it.
Now this is full AF dose of apixaban with clopidogrel. Do we know that that's as good as it gets? Or could one use a lower dose of apixaban?
In the ROCKET trial we were involved in, we had a lower dose of rivaroxaban, and that worked out quite well. But again, these trials were too small to be conclusive on the ischemic side. But for me, most interesting is the aspirin randomization in AUGUSTUS. It is 4,614 patients. And it showed, again, as expected, that leaving out aspirin dramatically reduced the bleeding, more than 50% reduction in bleeding.
And just stressing, all the patients got a P2Y12, about 92% clopidogrel. So it was apixaban plus athenoperidine.
Yes. And it clearly shows that clopidogrel worked very well. Even in this, it was mainly in ACS population, where clopidogrel was inferior to prasugrel and ticagrelor, but that was not allowed in this study. So on the ischemic side, there was some discussion with regard to aspirin or no aspirin, that leaving out aspirin resulted in a little bit more ischemic endpoint like MI and stent thrombosis, but very low numbers.
Very low numbers.
Yeah,
and
so
only numerically different, not statistically different.
No, not statistically.
So take-home message is that apixaban plus clopidogrel produced a very good result, reduced bleeding. We don't need triple therapy in these patients.
Yeah, and I think now we have nearly 11,000 patients in 4 trials addressing this, and therefore I think the optimal therapy is a NOAC rather than VKA, and you can drop aspirin cold turkey on the table.
Okay. Finally, just a few words about a very interesting long-term analysis from the POET trial, which is testing individuals who first of all got intravenous antibiotics for infective endocarditis, and now we have outcome to 3 years. Very interesting results. Catherine, what are your thoughts?
Yeah, I think this is, again, a very important study in that we can treat patients with the intravenous antibiotics for a shorter duration and then switch to oral antibiotics in carefully selected patients. And as we were talking earlier, I think it's really important to remember that the patients who went home on oral antibiotics, first of all, had a transesophageal echo to make sure they didn't have a paravalvular abscess. They had other markers that they were not bacteremic, their CRP's down, they're not febrile.
Yeah. So this is a very careful study where they made sure all of those markers were in the right direction, temperature below 38, CRP coming down, white cell count coming down, no abscess, and then they did very well on oral therapy.
Yes, and again, I think that having the infectious disease consultants in making sure that it's the right oral therapy and that it's effective is important, but it's a very impressive result. Should help reduce healthcare costs as well as ensuring excellent outcomes for those patients.
Terrific. Well, thank you both very much, Catherine, Otto, Freek, Verheugt. We've got some insights into studies today that are going to change practice.
Absolutely.
So thank you, and look forward to more tomorrow.
Yeah.
Right, thank you.
It was a pleasure. Thank you.